Good morning and good afternoon, everyone, and thanks for inviting me to take part of this third International Symposium on Post-TB. On behalf of Ernesto Jaramillo and Kerry Viney from the WHO Global Programs on TB and Lung Health, I will use the next presentation to introduce you to the concept of social protection, why social protection is important to address the needs clinical and social needs of people affected by impairment and disabilities resulting from TB-associated lung disease, and how the new WHO and ILO guidance on social protection for people affected by TB can support countries in addressing the persisting knowledge gaps that still hamper a wider use of these very important interventions. But let's start with a definition. Consistently with ILO, WHO defines social protection first and foremost as a human right, and it defines it as a set of policies and programs that are designed to reduce and prevent poverty and vulnerability throughout the life cycles and in times of crisis. Social protection, in fact, includes benefits that can address at least 9 critical contingencies over the life of any individual, going from maternity to the elderly, including disability. Social protection systems address all these policy areas by a mix of contributory schemes under the label of social insurance, non-contributory tax finance benefit under the label of social assistance, and legislation. In the slides you see that under each of the branches of social protection there is a wide range of intervention that is available. Under the social assistance group, it falls the disability grants. Disability grants, also called disability-oriented social protection programs, are interventions that are designed and implemented with the specific objective to support people living with disabilities. In the context of tuberculosis, we recognize 2 different types of implementation strategies when it comes to social protection, a TB-sensitive approach and a TB-specific one. The TB-sensitive social protection programs are programs that are not targeted specifically at household or individuals affected by TB. While not designed intentionally to address any TB-related objective, these programs can potentially affect the TB epidemic by including among their eligibility criteria people affected by TB, that is, either people with TB, people at risk of TB, and people vulnerable to the consequences of tuberculosis. These programs typically are not initiated by the TB program and are not under the control and the management of the health sector. TB-specific programs, instead, are programs that are exclusively addressed to people with TB and their households. Typically, these programs are initiated by and are under the control and responsibility of TB programs to respond to specific needs of people affected by TB that are not covered by the mainstream social protection programs operating in a given country. Such programs have the explicit objective to reduce TB incidence, mortality, and patient cost. Disability grants are an example of TB-sensitive program as they have the potential to address the needs of people affected by disabilities, including those affected by TB-associated impairment and disabilities. But the role of social protection in the fight against TB is far from being new. Even Robert Koch, in his famous speech for when he was awarded with his Nobel Prize, identified the social welfare centers as one of the most powerful weapon, if not the most powerful weapon in the fight against the disease. In these welfare centers, people were visited at home. According to this vision of these welfare centers, people were visited at home, were given money when needed, and when needed were provided with appropriate food and fuel for heating. Since then, the concept of social protection has evolved a lot, and social protection programs are now widely used all over the world, and we have accumulated a significant body of evidence confirming that social protection programs, especially in the forms of cash transfers, can double the chances of TB treatment success among recipients compared to the non-recipients, can halve the transmission of tuberculosis in the household, and can cut by a third the catastrophic cost that often TB-affected households face. While not specifically for TB-related disabilities, there is also vast literature that suggests that social protection program can have a critical role in addressing the clinical and social needs of people affected by disabilities, and can do that by providing ensuring a timely and equitable access to disability aid and rehabilitation services, by reducing stigma and discrimination, by compensating any financial loss and the prevention of long-term impoverishment often associated with disability, and by improving the health outcomes underlying the disability and reducing the health inequalities that result from disability. This evidence can for sure be transferred and to TB-associated disabilities, and the evidence that we have, they can be plausible and legitimately apply to the TB-associated disabilities. However, there is a limit. The evidence available suggests that still today a very limited proportion of people living with TB-associated disabilities have access to disability grants. Evidence that were gathered as part of a social protection baseline assessment conducted in South Africa in 2024 suggests that even if people with TB are eligible in principle to receive disability grants benefit, only a small minority eventually have access to these benefits. A number of barriers seems to hamper a wider access, and these barriers include the fact, for example, that applicants might be unfit to work in order to be eligible, and this excludes most people with drug-susceptible TB. There is also a high degree of discretion in the assessment of disability from the clinical doctors that perform the assessment of the eligibility. And this high level of subjectivity probably depends on the fact that there is no clear standardization and understanding of how to translate the clinical assessment of the lung and respiratory impairment, as well as other TB-associated disability, into the concept of disability that is more a social concept that is not necessarily translatable into clinical terms. People with TB that have tried to access disability grants have also complained about the complex enrollment procedures. Complex procedures that probably are the reason why people often have to face indirect costs associated to the enrollment process. Because of that, there are still a number of critical questions that need to be addressed in order to ensure a broader access to disability grants, and making sure that people suffering with TB-associated disabilities can receive social protection benefit as much as they deserve. These questions can be fundamentally grouped into four overarching questions. One is, what are the social protection needs of people affected by TB-associated disability? Another is, what are the main demand and supply side barriers to access that people with TB-associated disability experience? A third one is how we can reconcile the definition of and the assessment of disability from the clinical assessment that we conduct in the TB sector, and transfer it to the more social-oriented definition and understanding of disability that exists in the social protection sector. And finally, how can we establish effective and efficient referral systems across the TB and social protection sector? The social protection guidance from WHO and ILO aim to support countries in the implementation of effective, efficient, equitable, and sustainable social protection programs for people affected by TB. The content of the guidance can support countries to understand how social protection can be also used to address the needs of people affected by TB-associated disabilities, and can do that by providing its audience with essential notions on and a base of evidence to understand how social protection can contribute to end the TB epidemic and also address TB associated disabilities, by providing practical and plan on how to design inclusive and locally appropriate social protection programs able to respond to the needs of people affected by TB and people affected by TB-associated disabilities, and by providing a list of key concrete steps to implement effective social protection programs. In conclusion, social protection can help to address the health and social needs of people living with disabilities, including those affected by TB-associated disabilities. However, important operational knowledge gaps persist. The social protection guidance, WHO social protection guidance, can help countries in addressing some of this gap and improve the way we care for these people. This support to countries will be even greater when the guidance on social protection will be complemented by the incoming WHO guidance on the management for impairment and disability resulting from TB-associated disabilities. Thank you very much for your attention. Bye.